Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be discussing on one of the another interesting topic which you can see in your everyday practice, quite common. We call myocarditis. Meaning is very simple, inflammation of myocardium, either by infectious etiology or by non-infectious etiology. We'll call that as myocarditis. As usual, we'll be discussing under all these different headings. So myocarditis is an inflammatory disease of myocardium, which can be because of infectious etiology or non-infectious etiology. Non-infectious can be many: toxic, autoimmune, radiation, lot of conditions, infiltrations, etc. Depending upon the onset, you can divide into acute, subacute, and chronic. And anatomical localization wise, focal or diffuse. So usually the terminology which are very commonly utilized we can call classification or types or terminology. In etiological wise, viral, fungal, bacterial, drug induced, immunological, parasitic, radiation, infiltrations, etc. Depending upon onset and duration, acute, subacute, chronic. In chronic, active and persistent. And as far as area of involvement is concerned, localized and diffuse. Diffuse is also called generalized. So etiological classification, acute and chronic, by and large two most common words which are being utilized. There is one more word which is being utilized in etiological stages, that is called myocardiofibrosis, or also called myocard dysosclerosis. Prevalence wise or area wise, focal and diffuse. Diffuse is also called generalized. Severity wise, mild, moderate and severe. Clinical variants where you can come across rhythm and conduction disturbances, pain in cardiac region, and heart failure wise, different stages, variant dysfunction and functional classification. Chronic variety, very commonly it is because of different etiology. LVMENT classifies into fulminant, acute, chronic active and chronic persistent. There is some other terminology also utilized: acute myocarditis, fulminant myocarditis, giant cell myocarditis, chronic active, eosinophilic, peripartum. Biopsy wise, depending upon the type of infiltration, lymphocytic, eosinophilic, neutrophilic, giant cell, granulomatous and mixed variety. Grading wise, on biopsy classification, mild, moderate and severe, and also called as grade 0 or we call none. Distribution wise, focal, confluent, diffuse and reparative, that is in fibrotic stages. If we go through the etiology, the most common etiology is infectious and non-infectious. We divide into two big groups. Among infectious, viral, where adenovirus, Coxsackie virus, hepatitis C, HIV, etc. comes topmost on the list. While among bacteria, Mycobacterium, Streptococcus, Mycoplasma pneumoniae, and syphilis, that is Treponema pallidum. Fungal, Aspergillosis, Candida, Coccidomycosis, Cryptococcus, Histoplasma. Protozoal, very common is Trypanosoma cruzi. Among parasites, Schistosomia and Larva migrans. These are some of the common infectious etiology, out of which the viral is most common, Second common is bacterial. Fungal, usually in an immunocompromised host. Among non-infectious group, immune mediated, where you can get auto-antigen, or we usually use the word autoimmune, where you can get different variety in inflammatory bowel disease, Churg-Strauss syndrome, giant cell myocarditis, diabetes mellitus, sarcoidosis, SLE, thyrotoxicosis, even in Takayasu. While hypersensitive response in case of drugs like sulfonamide, cephalosporin, tricyclic antidepressant, dobutamide, and also in case of Wegener's granulomatosis. Toxic damage like cocaine, interleukins, ethanol, heavy metals, anthracyclines. These are the common. This is again a big list. Some of those we already discussed. Infectious etiology, bacterial, spirochete, fungal, protozoal, parasitic, rickettsial, and viral. Viral is most common. Immune mediated, toxic. Majority of them are we have discussed common causes. Still there is a big list. You can go through your at leisure time. We have discussed regarding the common virus. These are other list of viruses which you can come across. Among rickettsia, typhus, Rocky Mountain. Fungal, we already said, candidiasis, aspergillosis, and cryptococcus comes topmost on the list. Among protozoal, Chagas disease, toxoplasmosis, Leishmania, malaria, spirochete, syphilis, leptospira, even Lyme disease, helminthiasis, echinococcus, cysticercosis, filaria, trichinosis. Collagen vascular disorders which will produce autoimmune involvement, SLE, periarteritis nodosa, RA, dermatomyositis. Also once in a while you come across in case of acute rheumatic fever, giant cell myocarditis, sarcoidosis, Crohn's, that is irritable bowel, inflammatory bowel disease, Crohn's and ulcerative colitis, etc. Toxic is very commonly to the drugs like penicillin, ampicillin, methyl dopa, sulfonamides. Direct toxic effects, lithium, cocaine, even paracetamol. Environmental agents like lead, arsenic, carbon monoxide, spider, sting, scorpion, wasp, etc. and radiation also. These are drugs, big list of drugs. One of the most common, sulfonamide, ampicillin, two most common. And there is a big list, anticonvulsant, antitubercular, anti-inflammatory, diuretics, amitriptyline, methyl dopa, sulfonylureas, etc. These are immunological, we already told you, SLE, RA, scleroderma, dermatomyositis comes topmost of the list. Even giant cell arthritis, sarcoidosis. If you look among the percentage wise, so yes, bacterial is 22, systemic causes 30%, allergic 9%, parasitic 2%, protozoal 1%, idiopathic accounts for 8% and 28% is viral. So viral is a big group, viral, bacterial is another, so this becomes infective pathophysiology, and then comes what we called as idiopathic group. So viral, bacterial and idiopathic accounts for a major group, very major group, and even this you can put idiopathic one another group where you can't identify the exact etiology. A most simplified form of a pathophysiology, myocarditis can involve a small part of myocardium we call localized, or entire myocardium is involved, we call generalized. The onset can be acute like in case of viral and bacterial, while usually it will be chronic in case of autoimmune, tuberculosis, toxic, etc. It can be chronic. Because of inflammation, there will be damage to myocardial cell, and because of damage to myocardial cell, there will be necrosis, and that will release biomarkers like troponin, CPKMB. So those two levels will be elevated. The portion of the myocardial cell which is being inflamed will have poor mechanical contraction. So because of decreased contraction, the force of contraction will be reduced, and it can lead to, depending upon the chamber which is being involved, either right side failure or left side failure, or entire myocardium if it is involved, congestive heart failure. Because of inflammatory involvement of a myocardium, it can result into cardiac arrhythmias. Most common cardiac arrhythmia will be ventricular arrhythmias, which can be lethal. This necrosed myocardial cell will be replaced by fibrosis, and by and large it will be resulting into dilated cardiomyopathy or restrictive cardiomyopathy. On the ventricular side of inflamed myocardium, you can have a formation of a thrombus, and from that thrombus you can get thromboembolism. Three major mechanisms: myocardial necrosis from direct invasion, like in case of bacterial and viral. Also in case of parasitic, fungal, etc., it can produce direct involvement of the myocardium and necrosis. In case of autoimmune destruction, secondary to immune complex formation, it will release chemical mediators which will produce inflammation and destruction of myocardial cell. Or it can be because of production of endotoxins by different pathogens. In case of toxic damage, directly the effect of drugs or toxic material, it can produce direct damage to the myocardial cell. So pathogenesis wise, cardiac injury and activation of an immune response. Then you get an acute myocarditis which is called acquired immune response, and then person goes into what we call as a recovery stage, or there is a persistence of inflammation, and then person develops cardiomyopathy, which can be dilated or restrictive cardiomyopathy. By and large, there is one genetic susceptibility, and you can have an acquired viral infection which will result into myocarditis, which can be fulminant, which can be asymptomatic, or person can have a chronic myocarditis. Chronic will usually recover, may be complete or partial, and it can end into dilated cardiomyopathy. A fulminant variety, because of a acute complication, can end into death, sudden cardiac death, or may recover, which can be partial or complete. Asymptomatic group will also recover, may be complete or partial recovery, and may end into dilated cardiomyopathy. Dilated cardiomyopathy is more common. So viral infection will result into direct myocardial injury, which will be pathophysiology wise apoptosis, necrosis, and which can resolution can take place because of down regulation, and there is no further myocardial injury. Or because of apoptosis and necrosis, it can end into ongoing immune response, ongoing myocardial injury, and dilated cardiomyopathy. And because of direct injury, this can be secondary due to immune response, which can be innate response or acquired response. In acquired, T lymphocyte, B lymphocytes will take part, while in innate response, you will have a cytokine production, and that will produce damage. Now either this, there will be viral clearance which can resolve or which can end up into autoimmune myocarditis, and virus may persist and that can also end into autoimmune myocarditis, and autoimmune myocarditis can end into dilated cardiomyopathy. This is a vicious cycle, so indirectly person can recover completely or can end into dilated cardiomyopathy because of continuous damage. So first stage is infection and injury, second stage is acute myocarditis, and then it can end into dilated cardiomyopathy. So usually they say that first phase, second phase and third phase. So in first phase there is a direct viral damage. In second phase there is a viral mediated autoimmune myocardial injury, that is we call as acute myocarditis, and in third phase recovery and remodeling resulting into dilated cardiomyopathy. So viral replication, autoimmune injury and dilated cardiomyopathy. These are the three common phases we come across. So we usually say infection injury, acute myocarditis, and then comes dilated cardiomyopathy. So acute myocarditis, subacute myocarditis and chronic myocarditis. Usually in acute, myocardial necrosis, macrophages activation, release of different mediators, spontaneous resolution can take place. And that can, if there is no spontaneous resolution, it can go into subacute stage where there is an infiltrating mononuclear cells or there is a damaging cells like killer cells and release of nitric oxide, which will further ends into chronic myocarditis and which will end into what we call as dilated cardiomyopathy, which will finally go into congestive heart failure. During subacute stage, person can have a viral clearing, and in a chronic stage usually virus are cleared, there is absence of virus, but because of a chronic myocarditis damage, there is a myocardial cell damage, fibrosis, it undergoes dilatation, so it will give rise to dilated cardiomyopathy, and finally it ends into congestive heart failure. So acute phase, subacute phase and chronic phase. Acute phase will last for 3 days. From 4 days to 18 days, it will be subacute phase where you get a autoimmune response and acute myocarditis. And in a chronic phase, there is a continuous inflammatory process, damage to the myocardial cells, replaced by fibrous tissue, dilated cardiomyopathy, and person goes into congestive heart failure, which can be lasting for nearly 3 months. So viral infection, inflammation injury, decreased myocardial contractility, and person can go into what we call as a dilated cardiomyopathy, decreased cardiac output, congestive heart failure. Scarring can take place, arrhythmias that can also precipitate congestive heart failure. Also because of left ventricular and diastolic volume is increased because of dilatation, or we call dilated cardiomyopathy. Left atrial pressure is elevation, pulmonary edema, and that will end into congestive heart failure. So this is a histopathological picture, and this is what we call as an inflammation resulting into scarring and then dilated cardiomyopathy. As far as clinical picture is concerned, usually in an infective pathophysiology, person can present as a general symptoms like fever, myalgia, arthralgia, body ache, little fever with chills, loss of appetite, nausea, vomiting, etc. Person may be asymptomatic or symptomatic. Usually person becomes symptomatic when there is a acute involvement of a myocardium, which can produce cardiac arrhythmias. Because of acute involvement of a myocardium, myocardial contraction is poor, person can go into right ventricular failure or left ventricular failure, and when there is a massive involvement, person can go into congestive heart failure. Mural thrombus can form and it can end into thromboembolism. Myocarditis will produce chest pain. Along with myocardium, if pericardium is involved, we call myopericarditis, where you will get pericardial pain. And end result will be, by and large, dilated cardiomyopathy. Very rarely there will be restricted cardiomyopathy. Restricted cardiomyopathy is not very common. It is common with infiltrative variety of myocardial involvement, like in sarcoidosis, etc. So, presentation can be wide, right from asymptomatic to fulminant cardiac failure and sudden cardiac death also. So, fever, fatigue, myalgia, vomiting, diarrhea, etc. are non-specific symptoms. Person can have a chest pain mainly because of pericardial involvement and maybe partly because of myocardium involvement. So, common presentation is asymptomatic. One another presentation is cardiac arrhythmia and conduction disturbances. And if there is a ventricular cardiac arrhythmias, person can go into sudden cardiac death. Most common presentation is a heart failure, which can be because of dilated cardiomyopathy in a chronic stage, or person can have a heart failure because of severe inflammatory response by a myocardium, or heart failure can be precipitated by cardiac arrhythmias, which can be part and parcel of cardiomyocarditis. And heart failure person can end into dilated cardiomyopathy or can have a complete recovery, and if it is very fulminant variety, person can have a sudden cardiac death. So these are the different ways in which the person can present. So the most common presentation is good number of time asymptomatic. 60% of the patient will have flu-like symptoms. We already mentioned fever with rigor, body ache, arthralgia, headache, loss of appetite, nausea, etc. In an acute phase, good number of time because of an acute myocardial involvement, person can have a heart failure symptoms like shortness of breath, dyspnea. Maybe right if a person develops left ventricular failure, orthopnea. Myocarditis and heart failure can have a chest pain, and this may mimic acute myocardial infarction because of presence of troponin. Good number of time it is misdiagnosed, and ECG also shows changes. So ventricular dysfunction, ischemic chest pain, ECG showing injury pattern. Sometimes even there is an appearance of Q wave. Heart rate will be elevated, tachycardia. WBC count will be elevated in 25%, CPK will be elevated in 12%. Specific antibody may be elevated in myocarditis, particularly in case of a dilated cardiomyopathy. Because of cardiac arrhythmia, person can have syncope, palpitations, and on ECG you can demonstrate conduction disturbances like AV block, or person can have ventricular premature beats, ventricular tachycardia, ventricular fibrillation, and that can end into sudden cardiac death. Good number of time it is found almost in 20% of the people. And because of thrombus formation, you can have thromboembolism, particularly maybe systemic or pulmonary. If it is in RV, pulmonary, in a systemic, that is in LV involvement, you can have a systemic embolism. Chest pain is usually stabbing in character or dull aching pain, retrosternal, no radiation, not aggravated by exercise, not relieved by rest, not commonly associated with perspiration or we call prostration. Congestive heart failure signs are quite common like dyspnea, edema, puffiness of face, ascites, hepatojugular reflux present. Palpitation is very common when the person gets cardiac arrhythmia. Sudden cardiac death is common almost in 20% of the people. We already mentioned the non-specific symptoms like fever, body ache, arthralgia, myalgia, etc. In left ventricular failure, you can get cyanosis. Hypotension is also more common with left ventricular failure. You can have edema in case of a right ventricular failure, and if there is a combined, we call it a congestive heart failure. JVP will be elevated. Basilar crackles, ascites, and peripheral edema suggest right ventricular as well as a left ventricular failure, we call as congestive heart failure. In cardiovascular system examination, invariably we don't get any evidence of cardiomegaly, but you can have a tachycardia, cardiac arrhythmias. You can have a murmur appearance because of involvement of the myocardium, which can produce involvement of a papillary muscle, can end into cardiac murmurs. Cardiomegaly may be seen in some cases where there is a dilated cardiomyopathy. Person can have atrial or ventricular arrhythmias. S3, S4 sound will be common in presence of congestive heart failure. You can have a murmur of mitral regurgitation, of tricuspid regurgitation. So on apex, you will get a systolic murmur. When there is a pericardium which is being involved, you can get a pericardial rub. RV dysfunction will produce JVP elevation, edema, hepatomegaly, hepatojugular reflex present, and in case of a LV dysfunction, you will have a S3 at apex, you will have a basal crackles, cyanosis, orthopnea, blood-stained frothy sputum. In sarcoidosis, you can have a lymphadenopathy. In rheumatic fever, you can have other criteria like rheumatic arthritis or erythema marginatum, chorea, subcutaneous nodules. You can see those. In hypersensitive or eosinophilic myocarditis, you can have a rash, pruritic maculopapular rash. Giant cell myocarditis, you can have a sustained ventricular tachycardia. In peripartum, heart failure will develop towards the end of pregnancy or after pregnancy. When it is after pregnancy, we call it a postpartum cardiomyopathy. Usually the word very commonly utilized is peripartum cardiomyopathy, which is again a dilated variety. For investigation, clinical examination is helpful. X-ray chest may show you mild cardiomegaly with pulmonary congestion, and in case of a right ventricular failure, you can have a pleural effusion. ECG may show you ST depression or ST elevation, T-wave changes. Occasionally you can have a Q-wave appearance. You can have an abnormal conduction like QT prolongation, conduction blocks, first degree, second degree, complete heart block, or even bundle branch block, quite common. Echocardiography will show you abnormal thickening of ventricular wall or abnormal size of the ventricular wall. Dysfunctions will be seen, right ventricular or left ventricular dysfunctions, dyskinesia, hypokinesia or akinesia. Increase in the ventricular's volume size because of dilated cardiomyopathy. Decrease ejection fraction. In laboratory parameter, you can demonstrate C-reactive protein positive. You will have a globulin level increased, IgG, IgM level will be increased, ESR will be elevated, troponin will be positive, even SGOT will be elevated, CPKMB will be elevated. You can have an antibody against the infective organisms. You can have an antibody against cardiomyocytes, which are again showing you autoimmune disorders. You will have a T cell marker in the form of a CD count will be abnormal. Radioisotope study can show you the damage to the myocardium, and endomyocardial biopsy can show you histopathological classification and type of cellular infiltration. There are some diagnostic criteria for myocarditis. If you come across 2 positive, suggest myocarditis. 3 positive category compatible with myocarditis, and if there are 4 positive criteria, then you come across high probability of myocarditis. What is there in a category 1? Symptoms. Clinical symptoms of heart failure, fever, viral prodrome, fatigue, dyspnea. These are all non-specific symptoms. Chest pain, palpitation, syncope, pre-syncope. In category 2, echocardiographic evidence by means of regional wall motion abnormality, ventricular chamber dilatation, hypokinesia, akinesia or dyskinesia, regional cardiac hypertrophy, laboratory marker by troponin elevated, and also you can demonstrate anti-myosin scan can show you myocardial damage. Coronary angiography will be absolutely normal, and there will be absence of reversible ischemia on perfusion scan. This is called category 2. Category 3 is cardiac MRI, which will show you recovery sequences or delayed perfusion scan can be done, and that will be either positive or negative. Category 4 is myocardial biopsy and histopathological evidence, or you can go for molecular analysis where you can show presence of viral genome by PCR study. You can divide into different stages like fulminant, subacute, chronic and chronic persistent, where onset, left ventricular function, biopsy, clinical history and histopathological outcome is taken. In fulminant variety, usually you will come across severe dysfunction. It is acute in onset. Biopsy will show you multiple foci. Clinical history, either person recovers or person can have a sudden cardiac death. And usually in fulminant variety, you can have, if person recovers, it can be complete resolution. In a subacute variety, usually it is moderate dysfunction, slow in onset. Biopsy will show you active or borderline involvement. There will be starting of a dilated cardiomyopathy. Person may have a complete resolution. In a chronic, usually there is a giant cell fibrosis. Person can develop restrictive cardiomyopathy or dilated cardiomyopathy. There is a slow onset, moderate dysfunction, and as far as biopsy is concerned, it can be active or borderline. But in chronic persistent, usually person do not have more amount of LV dysfunction. It biopsy wise active or borderline. By and large, there is a normal left ventricular function, and there is a constant histological ongoing damage which can be seen. We have already shown you these 3 phases, that is viral phase, immune response and remodeling, or we call repair. And depending upon that, you can decide regarding what treatment can be given. So at your leisure time, you can go through. So usually in this, we require to identify the etiology by blood parameters to demonstrate presence of virus, or by PCR, and you can give antiviral treatment. In phase 2, you will demonstrate presence of antibody, or you can go for myocardial biopsy which can demonstrate immune biomarkers. You can show myocardial injury by means of troponin present, and in that stage you will require immunosuppression therapy. While in remodeling, usually echocardiography will prove that there is a damage and person has gone into dilated cardiomyopathy, where ACE inhibitor, beta blocker, aldosterone antagonist, and you might require a mechanical support. Investigation, we have told you, CBC can show you leukopenia or leukocytosis. ECG may show you blocks, cardiac arrhythmias, tachycardia. Among cardiac arrhythmia, ventricular or atrial arrhythmias. Echocardiography will show you LV dysfunction or RV dysfunction. Enzymes, biomarkers, SGOT will be elevated, LDH1 will be elevated, CPKMB will be elevated, troponin I also will be elevated. Endocardial biopsy will tell you histopathological grading, grade 1 or phase 1, phase 2 and phase 3. X-ray chest might show you little amount of cardiomegaly with pulmonary congestion, and in case of congestive heart failure, even pleural effusion. MRI may be helpful. Viral study is important to identify the involvement. ESR and HSCRP will be helpful to have inflammatory process, and it will be inflammatory biomarkers. You can go for rheumatological screening, viral antibody screening and PCR test, and tissue cytokines level in case of a giant cell myocarditis, ANA, SLE in case of a collagen disorders. Cardiac enzyme will just tell you myocardial cell involvement and damage, injury. WBC will give you an idea regarding bacterial or viral. ESR will tell you regarding inflammatory process, and PCR will give you idea regarding the type of viral involvement. ECG is non-specific test which can tell you the involvement of myocardium by means of AV blocks, STT changes, Q wave appearance, etc. Troponin also gives you a non-specific elevation. Creatinine, CPKMB, and we call SGOT, again non-specific. Antibody against virus is important. Scan will give you again idea regarding the severity of a myocardial damage. Echocardiography will give you a functional involvement. What are the functions which are being involved because of myocardial involvement? Biopsy will give you histopathological diagnosis, and that is very important. So cardiomegaly may be there because of little dilatation. You can get dilated cardiomyopathy, and you can have a pulmonary congestion. You can develop a pericardial effusion and pulmonary congestion. You can have a pleural effusion secondary because of congestive heart failure. So again dilatation. You can see this is dilatation. ECG, we have told you sinus tachycardia, QT prolongation, T wave changes, ventricular arrhythmia, conduction disturbances, bundle branch block, etc. can happen. If there is a myopericarditis, you can have changes of pericarditis in ECG. So there are all non-specific changes, non-specific T wave STT changes, sinus tachycardia, ST segment elevation, conduction disturbances, atrial and ventricular arrhythmias. So you can have all those type of changes. Good number of time it is misdiagnosed even as MI. You can see STT changes, T wave changes, STT changes can be seen quite frequently. You can see this, but you will have to correlate with the clinical picture. Echocardiography will tell you regarding regional wall abnormality, thickening of the myocardium, ventricular chamber size, hypokinesia, akinesia or dyskinesia, LV function, LV ejection fraction, etc. can be identified. Presence of thrombus, pericardial involvement, all you can identify. So echocardiography is a good parameter. You can even identify fulminant myocarditis and acute myocarditis by echocardiography. So echocardiography is a very important tool. MRI usually with scan, that is indium I-111 anti-myosin scan, can be more helpful to find out the amount of damage. Endomyocardial biopsy is a gold standard because it gives you histopathological diagnosis and severity of involvement of the myocardium. So this is regarding an endomyocardial biopsy. Good number of time it is being done and it is indicated, and you can get an histopathological classification. MRI with scan can give you the severity of involvement of the myocardium. These are different type of scans which are there. Gallium scan, anti-myosin scan. Angiography almost is of no use. It is mainly to rule out a cardiac ischemia in a suspected case of MI. You will have to differentiate cardiomyopathy, valvular heart disease, ischemic heart disease, and pericardial involvement because of other etiology. Management will be depending upon the stage in which he comes. By and large, the most common presentation is a congestive heart failure, so management of congestive heart failure. Anti-inflammatory drugs, prevention of thromboembolism by anticoagulations. Treatment of blocks, maybe by temporary pacemaker. And as far as autoimmune is concerned, prednisolone, or we call corticosteroid with immunosuppression treatment, may be useful. So management is stabilization of hemodynamics by inotropics drugs, balloon pumps, ventricular assisted device. For remodeling and prevention of dilated cardiomyopathy, ACE inhibitor, beta blocker, aldosterone antagonist. If it is autoimmune, immune suppressions like steroid, azathioprine, interferon, immune absorptions. Regular follow-up, regular checkup, and in late stages you might require a cardiac transplant, or you might require ventricular assisted device or impella. If it is bacterial infection, antibiotics, standard treatment of congestive heart failure, treatment of arrhythmias, limitation of exercise depending upon the cardiac state, steroid usually commonly given in an autoimmune variety. Person might need an extra cardiac support like LVAD or intra-aortic balloon, counter pulsation balloons in severe congestive heart failure. Very rarely they require a heart transplant in a irreversible damage, or we call end stage. Prognosis will depend upon the severity of involvement. So this is how you suspect and how you approach, that is given in detail. So if it is viral infection, you might require interferon, and if it is an autoimmune, immunosuppressive drugs like steroid and azathioprine, which is being preferred. So treatment of arrhythmia, treatment of congestive heart failure is the prime, and prevention of thromboembolism with anticoagulation. Along with that, antiviral drug for viral infection, antibiotic, antifungal depending upon the etiology. Treatment of cardiac arrhythmias, and in case of blocks, Person might require a pacemaker, immunosuppression therapy in case of autoimmune disorders, anticoagulants for thromboembolism, immunoglobulins may be required in autoimmune disorders, and late stage, if person does not respond, you might require even a heart transplant. So prevention is always better. For prevention, usually vaccination may be done for some of the organisms. Complications, most common complication is congestive heart failure, or person might have a right ventricular failure, left ventricular failure, cardiac arrhythmias, pericarditis, pericardial effusion. In a recovery stage, person can develop dilated cardiomyopathy or restrictive cardiomyopathy, thromboembolism, which can be systemic or pulmonary, and some person can have a sudden cardiac death. Prognosis, a person has got severe fulminant variety, prognosis is poor. And if a person who has gone in a cardiogenic shock, again prognosis is poor. So in these two conditions, usually prognosis is poor. In a chronic variety, person can go into dilated cardiomyopathy. So I end my lecture here. I hope this lecture will be very helpful to you. Once in a while, you will come across this group of people. If you keep this thing in mind, you will be able to pick up such cases and you can prevent late complications. If you diagnose them early, you can prevent those complications.